So if we look at the geography of the rural South, is that the population, as you expect, is dispersed over large geographic areas. And small town culture and dynamics play a part of the lives of many of the people in the South. Isolated social networks and lack of public transportation and other services. So you may have people who, from the clinic where they get care, may live a couple of hours away. And that's particularly problematic when you have no transportation, you don't have money, or maybe you don't have the support of family who can take you to services and care. Other things, long distances to the health care, as I just mentioned, and the thing with the Deep South is we have large areas of medically underserved areas in this Deep South. Here's just for Alabama as an example, and most of the other southern states I would expect would reflect this to a great extent. The tan areas are areas that are designated medically underserved. In Alabama, it's almost the whole state. And then when we look at the health professional shortage areas, again, it's primarily the whole state, with the green being those are for the total population, but the red being those that have particularly low-income populations and their health professional shortages. So these have a huge impact. Also, to me, one of the biggest challenges we face in addressing this epidemic is the poverty. And this is really true and with women in our studies. They deem to be single moms living alone with young children, not much family support. The huge majority of all the samples of all the studies we've done, their household incomes fall below $10,000 a year. I can't even raise my pets on $10,000 a year, much less children. I mean, that's, the economy is tough. And they lack personal transportation. So getting these people into care is really tough. And the biggest, they live in substandard housing, live far away from their providers. In our studies where we sent out peer counselors to do home visits, on average they drove 90 miles to do these home visits with women from the clinics. And the large majority exhibit significant depressive symptoms. The last two studies I've done with women, 92 we screened of the women we screened to be in the study, 92% had depressive symptoms greater than a score of 16 on the CESD, which, if you know the CESD, it's highly correlated with clinicians' diagnoses. And more recently, the one was 78%. We maybe see an improvement with treatment, but still 78%. And rural areas already are documented to have higher levels of depressive symptoms, but you can see it's even much higher in this population. And as I mentioned before, the common pattern of dropping in and out of care with this population, which has a lot to do with these social and environmental variables, not because they don't care. As I mentioned, high unemployment and economic vulnerability. And along with women goes along economic dependency and sexual concurrency. Anecdotally, what I hear over and over is that some of the women are at high risk because their sexual relationships are a source of income, monies to support them. And many women sometimes will have multiple partners because this one pays their rent, this one pays other things. That's what they've learned to do is survival. And so that's a huge problem that contributes. Interestingly, though, in areas that I've been in where there have become jobs available, where a plant moves in or whatever, even if it's a low-income job, providers are saying when these women get jobs, their behaviors are changing. They're not doing all the risky things because they can support themselves. So an economic intervention would go a long way to helping us to address some of these problems. Also with women, they always come last on their list of priorities. And as I mentioned before, the high rates of depression. You got to give them credit, though. These women are very resilient and have excellent survival coping strategies. However, the problem is, to live well with the disease, you've got to get beyond survival, and you have to learn ways that improve your quality of life, and it's just not surviving. You have to learn better and more effective coping strategies. And another issue I've found with the women is that they're reluctant to get care from people who are non-HIV care providers. And that's going to be a growing issue with us as they develop multiple morbidities, because many of them are not getting care for their other medical conditions because they do not want to have to go to a non-HIV provider and tell them, I'm HIV positive, because they've experienced in the past where they've either been told, no, I will not treat you, or they're treated differently, and that fear lives with them.